Welcome. We are delighted to present this series of educational videos, Pituitary 101, featuring Dr. Louis Blevins, a program exclusively produced by Pituitary World News with important information about the systems that drive pituitary function and, importantly, how those systems are affected by pituitary disease. Here's Dr. Blevins.
Welcome back to Pituitary 101. This is episode 7, and I'll be discussing the prolactin system so that you can understand it in detail. Let's go to the first slide. Jump right in here. So as you can see, they're higher centers. Normally that means the brain and other things that impact this particular system here. Stress, food intake, sexual activity, all those things can lead to prolactin increase. This is one of the unusual systems. Most of the systems, the hypothalamic hormones have a positive impact on pituitary function. That's a predominant control over that pituitary hormone. This is one of two where the most of the impact is negative. So dopamine is the transmitter produced, or hormone transmitter, I think it's both, produced by the hypothalamic cells, and it travels to the pituitary gland and actually inhibits prolactin secretion to keep it from rising too high. That's the way this system works. So if you have a problem with your hypothalamus or your pituitary stalk, you can't get dopamine to the pituitary, and the prolactin level rises in that setting. So that's interesting. It actually serves as a really good test to help us localize disease. If we see a lesion in the pituitary and a high prolactin, it's not a prolactinoma, it's probably interfering with the pituitary stalk. If we see a lesion that's in the pituitary stalk, we usually would see not only diabetes insipidus, but hyperprolactinemia, and other hormones can be deficient. So it's very curious, and it's kind of nice that it's this way because it helps the pituitary endocrinologist make sense of hormone abnormalities, that if you can't get dopamine to the pituitary, the prolactin level rises. There is some positive control from the hypothalamus, for example. The serotonergic system, vasoactive intestinal peptide, and TRH and GnRH all stimulate prolactin release. This comes to attention occasionally in patients who have primary hypothyroidism where their thyroid fails. Their TRH levels rise to produce TSH, and that TRH sometimes causes the prolactin to rise. And we can see pituitary hyperplasia even in some of those patients. So not every cause of prolactin is due to a pituitary tumor. There are other things going on with this unit that can raise prolactin. Prolactin's a fascinating molecule, and this slide doesn't give it the full credit that it deserves. It focuses on the fact that the breast is a target organ here for prolactin. Prolactin does a number of things within the lobules and the acini of the breast duct tissue to lead to breast milk production. And one of the common symptoms and signs of a patient who has a prolactin excess is the production of breast milk or a clear fluid that's unusual due to prolactin excess. But prolactin also plays a role in the immune system regulation and may play a role in feeding behavior as well. So it's more complex than is described here. There are some interesting spinal cord pathways that can be activated by stimulation of the breast by suckling of a baby, or a chest wall injury with a rib fracture, or herpes zoster or shingles can do the same thing. And those pathways will go back to the brain and stimulate prolactin release so that you can see hyperprolactinemia with chest wall injuries, rib fractures, suckling of the breast by a baby, nipple stimulation. So we'll often tell people no sex, no nipple stimulation. If they have a baby, no breastfeeding and things like that before they get their prolactin levels checked in the morning, just because of this physiology. One of the interesting things about prolactin is what it does to the gonadotropin-releasing hormone pulse generator, which I described in other videos, part of this series, is necessary for normal function of LH and FSH. And prolactin is a disruptor of that pulsatility, so it will actually inhibit the pulsatility of GnRH and therefore can shut down both the female and the male reproductive systems by interfering with that GnRH pulse generator and leading to low LH and FSH levels and discoordinated function of the gonads in patients with hyperprolactinemia. So that's all very fascinating when we think about this particular system. When it comes to measuring prolactin, it's done by immunoassays, and there are a couple of things that you need to know. Prolactin usually circulates in the bloodstream as what we call free prolactin or monomeric prolactin. Some patients develop dimers where there are two molecules attached to each other. That's called big prolactin. And we recognized, 20, 30 years ago, there were forms of prolactin that were called big prolactin. And it was thought that these prolactin aggregates or big prolactin was just largely prolactin aggregates where they were so large they didn't get filtered by the kidney. It accumulated in the bloodstream, but it wasn't biologically active because it's only the single prolactin that can hit the receptor and have its activity. What we now know is that some patients with these big prolactin levels have antibodies against prolactin. It's almost like autoimmunity against your prolactin. You can have IgJ or IgG antibodies against prolactin. They don't get cleared by the kidney, so the total prolactin goes up because of these. Think of these as the binding proteins, if you will, but in this case, these proteins are immunoglobulins. They're not present in everybody, but they're present in some people. The total prolactin goes up, but the free prolactin will be normal. So we'll see these patients. The clue is they don't have pituitary disease. Their prolactin is 100. But they're still having regular menses. There's no hypogonadism. And we can actually do a special prolactin assay called a macroprolactin test, where they'll do special things to the bloodstream and prove that it's prolactin that's bound to antibodies versus prolactin that's free. And they'll give us the macroprolactin and the monomeric prolactin level. That often solves the case in these patients. Their prolactin is really not elevated. It's just that the total prolactin is high, but the prolactin that really matters is normal. There's no need to treat these antibody problems. We just tell patients to stay away from surgeons and not let someone operate on your pituitary because your prolactin's high. And don't take medications because if your menses are normal and your fertility is normal and your gonadal function is normal, if you're a man, you don't need treatment for this condition. It's just a curiosity that sometimes helps us understand why someone's prolactin's elevated. So if you have a high prolactin, and everything looks normal, no tumor on the scan, we're probably going to check this blood test, and you should certainly ask your doctor for it if that seems to fit your situation. One of the things to keep in mind about this is sometimes people with prolactinomas also have the antibodies, so those are the ones where we have to scratch our head and make decision making based on there is a tumor there, it's probably a prolactinoma. If the patient doesn't want surgery to get rid of it to know for sure, and to know for sure, then we would treat with medicine, but we would still check the macroprolactin to determine the free prolactin to guide our treatment. Another situation that's less of a problem now than it used to be 20 to 30 years ago is the hook effect. And this is different now because we have better assays to test for prolactin. I'll try to explain this by using this diagram that I found on the internet. I thought it was pretty good. And it points to the fact that, and this is a two-site immunoassay. So it's like the one of the earlier videos I showed you that there's an antibody used with biotin to bind to the test tube wall, and that antibody finds prolactin in the bloodstream, and then they throw in a radiolabeled antibody into the test tube and mix it up, and then that antibody finds prolactin as well. And these antibodies is called a sandwich assay. So you got an antibody with a radiolabeled tag, a prolactin molecule, and then an antibody that's fixed with biotin to the test tube. And in this setting, you wash all the contents out. However much radioactivity remains in the tube is, as shown down here, proportional to the prolactin concentration. So radioactive signal is proportional to the prolactin concentration. That's the way these sandwich antibody assays usually work. Fortunately, and it used to be said that with the prolactin under 200 or 100 in some assays, this is linear. After that, you lose the linearity and it falls off, where you can actually underestimate the prolactin in the system when the prolactin's too high. The newer tests go up to 4,000. Like the assay we use at UCSF, we can see linearity from 0 to 4,000. Some other assays, you only see linearity from 0 to 200. But, and the reason being is what's called the hook effect. And I think that because this is the hook in the curve is why it's called the hook effect. But basically, you have that tube with the biotinylated antibody that picks up the prolactin, but and you also throw in the radioactivity, but you have far more prolactin than you have antibody. So these prolactin molecules all block these antibodies getting to these prolactin molecules, and in the end, if you have too much prolactin, you get a level that will be slightly elevated or even normal when really the level might be 2,000 to 3,000. So those old antibody assays, they had to dilute the samples and keep measuring in different serial dilutions to figure out what the real prolactin was. Fortunately, we can go up to 4,000 now. Who cares if it's 20,000, if it's 4,000, because it's not going to change anything. So I like the newer assay that has the linearity, but this is called the hook effect. It's relevant in the fact that if you had a macroadenoma and a prolactin of 150, in the old assays, that could be a prolactinoma that you might treat with medication. But since the prolactin's under 200, you might go to surgery. But if you do the right assay with the dilution or do the proper assay that has better linearity, you'll find out that that prolactin level may really be 600 or 2,000 or whatever, and you might choose medical therapy versus surgical therapy in that setting. So it's useful in that arena, and this is how we learn to think about the hook effect and what to do about it. Another important thing to recognize is that I mentioned that prolactin can interfere with that GnRH pulsatility and lead to central hypogonadism. And imagine a woman who's pregnant. She loses her menses. Is she hypogonadal, or does she have a prolactinoma? Well, prolactin levels rise during pregnancy, as you can see in this gauge. So it's often hard to say, is this gray zone is the levels of prolactin in normal pregnancy. You can see that by 24 weeks of pregnancy, the average prolactin is probably between 70 and 80. And at the third trimester of pregnancy, levels can be as high as nearly 200. One study says 600, or even certainly above 50. So prolactin levels rise during pregnancy. So anytime we see a young woman who's of reproductive age who has a high prolactin and no periods, we do a pregnancy test, and that's just important because of this recognition. If she has a prolactinoma, it's probably just the prolactin disrupting the function of the pituitary gonadal axis in that setting. Hypoprolactinemia can be due to, as I mentioned before, disease of the pituitary stalk. If you can't get dopamine to the anterior pituitary, that will cause the prolactin level to rise. In that setting, it usually ranges between 50 and 100. Some medications affect the dopamine receptor and block dopamine action, and that can raise prolactin. Usually in that setting, prolactin levels are 150 or less. I've seen them as high as 200 in patients taking a drug known as risperidone. I think that results in the highest levels that I've seen. Patients with microadenomas can have any degree of elevation in prolactin from 25 to 40 or even all the way up to 200 or 300. The highest I've seen in a microadenoma was 600. Usually if there's a big pituitary tumor and a prolactin over 200, we consider that to be a macroprolactinoma. And those levels vary greatly depending on the type of tumor that the patient has and the functional ability to secrete the hormone in the bloodstream. The highest prolactin I've seen is 20,000. I've seen patients with macroadenomas and prolactins of 125, where you think it's a non-functioning tumor, you take them to surgery and it stains for prolactin, turns out to be a more primitive cell tumor. So that's usually the situation where we use the degree of level to help us decide what's going on in conjunction with the history and the radiographic data. The last thing I want to mention is hypoprolactinemia, and there are case reports of what we call Sheehan syndrome, and actually Simmons reported one of the first cases of pituitary deficiency in a woman who had sepsis after pregnancy and had pituitary failure and thus low prolactin. And all these patients with this condition usually have trouble breastfeeding, and that's often the first sign that they have hypopituitarism. If they've lost the ability to make prolactin, they can no longer breastfeed their children. And that hypoprolactin, that's the main situation where a low prolactin level has clinical relevance, is in breastfeeding. I've had a number of women who have hypopituitarism and they don't make any prolactin at all and they have trouble breastfeeding. So hypoprolactinemia can be a clinically relevant problem as well. But most of the time we're focused on the evaluation and management of patients with a high prolactin. If you'd like to learn more, I'd encourage you to check out some of our other videos and podcasts and articles at pituitaryworldnews.org. Thanks for listening, and stay tuned for another episode.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a non-profit organization and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. Every contribution helps, no matter the size. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org. We welcome your comments and suggestions. Thank you, and thank you very much for watching.